So we are live started.
Good day, friends, and welcome to this edition of Diabetes Essentials. Over the past few weeks, we've been talking about various aspects of diabetes management. These days, we are talking about complications. So, our focus right now is on microvascular complications, and today we'll be talking about diabetic nephropathy or kidney disease. Diabetic nephropathy or diabetic kidney disease is a major complication of diabetes. It's an important complication because, number one, it is very common. Number two, the treatment is quite challenging. And number three, in spite of our best efforts, sometimes the outcomes are suboptimal. And this leads to an unnecessary burden of end stage renal disease. Let's take the opportunity to look at some terminology. Diabetic kidney disease is kidney disease that occurs directly because of diabetes. However, a person with diabetes may have kidney disease due to other reasons, maybe an infection, maybe an autoimmune condition, maybe an unknown condition. All this put together is diabetic nephropathy. Diabetic kidney disease, DKD, is one type of CKD, chronic kidney disease. Chronic kidney disease is staged according to levels of albumin excretion and EGFR, estimated glomerular filtration rate. We'll talk about that later. But when CKD reaches the need for a renal replacement therapy, RRT can be either hemodialysis or peritoneal dialysis or kidney transplant. Then we call it CKD stage 5 or end stage renal disease. Now, if we are able to pick these up early, then we will actually be able to prevent complications of diabetic nephropathy. Some of the common symptoms that your patients may complain of will be swelling of the feet, pallor, easy fatigability, and high blood pressure in spite of taking one or two or three types of medications. These symptoms occur late sometimes. So it is a good idea to even note increase in blood pressure or increase in requirement of treatment for blood pressure. You will be able to pick your patients up much faster. But it would be best if we can pick up our patients before they become sick. To do this, we have to screen them. And one way of screening is to check for a urine microalbumin. So we'll talk about that as well later on. But you must get a urine routine test done. In urine routine, they will check for albuminuria. But if you want to check earlier, if you want to pick up earlier, then you have to do a urine microalbumin test. This is also very easy to do. It's a dipstick test which can be done. We should also calculate EGFR, estimated glomerular filtration rate. EGFR is calculated with calculators, very easy, available online, you can use on your phone. And you need a serum creatinine from a good laboratory, from a standardized laboratory. So even if there is no sign or no symptom, if you can find albuminuria and or reduced EGFR, it means your patient has diabetic kidney disease. So we should begin treatment early. However, if your patient has got an active urinary sediment, this means there are many RBCs or casts or crystals in the urine routine test. Maybe albumin levels are increasing rapidly. They have reached nephrotic syndrome. Or the EGFR is declining very fast. Or the patient does not have any other microvascular disease like retinopathy. It means the patient may have some other cause of kidney disease. So we have to screen for that. It may not necessarily be diabetic kidney disease. In our clinics, when we assess patients with the renal disease, we have to look at various aspects. The renal pentad reminds us of what to do. Of course, we are worried about renal function, which is EGFR and albuminuria. See in this pentad, the point right at the top. So we will measure albuminuria and EGFR. But we should also be mindful of diabetes control, HbA1c, and we should avoid hypoglycemia. Because in patients with kidney disease, hypoglycemia can occur. In fact, one of the common symptoms of kidney disease is sudden onset of hypoglycemia in a patient who was earlier well controlled. Not only should we focus on diabetes control, we should also look for other conditions like blood pressure and dyslipidemia and manage them as well. So this would be in all people with diabetes. Do screen for acute health concerns. And in chronic kidney disease, two acute health concerns are dyselectrolytemia and also urinary tract infection or obstruction. So we should screen for these. And then chronic health concerns like iron status and bone mineral health. Our patients with CKD, with chronic kidney disease, may have low iron or low ferritin levels or a low transferrin saturation, and they may have bone dysfunction. The term used is renal osteodystrophy. They may have osteoporosis or osteomalacia or a mixture of both. So all these things, all these 10 things should go on in our mind when we are managing patients. If you have somebody with repeated acute concerns, there is always some troubleshooting going on or the other, then we refer to a nephrologist. But for the most part, checking renal function, diabetes control, control of blood pressure and lipids, ensuring adequate iron and calcium and vitamin D supplementation, these can be done by all of us. It is also important when you have a patient with kidney disease to think of the heart, because there is a bidirectional relationship between both. So if you have a patient with heart disease, the chance of kidney disease is more. If you have a patient with kidney disease, the chance of heart dysfunction or heart failure is more. And these are the types of cardiorenal syndromes that we speak of. We already mentioned that every year we must estimate urine albumin and EGFR. If your patient has an urine albumin excretion of more than 300 milligrams per gram of creatinine and or an EGFR of less than 60 ml per minute, then we can also monitor twice annually or even more than that if needed. You have to be more aggressive. How do we stage and how do we treat our patients? The more the albuminuria and the lesser the EGFR, the more the treatment that is required. So if you have a patient with an EGFR of less than 30, it would be a good idea to refer to a nephrologist, because the nephrologist will begin preparing the patient for renal replacement therapy. But that doesn't mean that we shouldn't refer before if the EGFR is more than 30. Even here, if the EGFR is more than 30 and there is severe albuminuria, or the EGFR is more than 30 and there is always some acute complication or the other going on, it would be a good idea to refer to a nephrologist. If the EGFR is fairly okay and the albumin levels are only in microalbumin state, then you can continue managing the patient. Referring to a nephrologist does not mean that we will abdicate all responsibility. The patient will come back to us and we will take care of the patient's day-to-day needs. How do we do that? Let us look at 4 aspects. Number 1, glucose control in a patient with diabetic nephropathy. Ensure good glucose control, avoid hypoglycemia. As much as is possible, if the EGFR is more than 30, use SGLT2 inhibitors. Number 2, along with glucose control, we need blood pressure control. Bring the BP to target. 130/80 would be a good target for most patients. As much as possible, use ACE inhibitor or ARB. Not only do we have to control glucose and blood pressure, we also have to reduce CV risk. So where required, you will give a statin, that is to everybody with DKD, diabetic kidney disease. And where required, you will give antiplatelet drugs like aspirin. The guidelines actually are that everybody with diabetic kidney disease should get a statin irrespective of lipid profile at baseline. So you do not even need to wait for the lipid profile results. You should start a statin. The fourth and equally important part of managing DKD is renal hygiene. Now, what does renal hygiene mean? Renal hygiene means preventing, minimizing, or treating urinary tract infection, urinary tract obstruction, other modifiable causes of renal dysfunction, like obesity, like tobacco intake, like taking pan. So avoid substance abuse. Renal hygiene will also include avoiding dehydration, avoiding unnecessary use of renotoxic drugs like NSAIDs or radiocontrast material. So keep the kidneys hygienic, control blood pressure and glucose, and also reduce CV risk. If we are able to get all the numbers right, the hemoglobin, the calcium, the glucose and HbA1c, the blood pressure, the lipids, and we are able to give antiplatelet drugs where required and ensure good renal hygiene, then our kidneys are safe. So what do we do? Let's talk about this in more detail. For glucose control, give SGLT2 inhibitors if possible, if EGFR is more than 30. Insulin would be a preferred drug of choice. If your patient is obese, you can use GLP-1RA. If your patient does not agree for insulin at all and glucose control is not all that bad, you can use a modern sulfonylurea like glyclazide MR. Glyclazide MR 30 milligram would be a safe drug to use here. We must bring the BP down to 140 by 90 or less, and the first choice would be ACE inhibitor followed by ARB. Do note that most people with diabetes will need a combination therapy. So out of all your patients of diabetes, 2/3 may require dual therapy to control blood pressure. So along with ACE inhibitor or ARB, they may need a diuretic or amlodipine. When it comes to DKD, that percentage will go up. So around 80 to 90% of all your patients will require 3 drugs for controlling blood pressure. So do not hesitate. If, however, your patient is not responding to even 3 drugs of blood pressure lowering category, then maybe it would be a good idea to refer to a specialist and see whether there is any other reason that we are missing. One common reason is renovascular hypertension. For renovascular hypertension, there are many tests that are done, but a screening test that you can get done is a renal Doppler, if your ultrasound colleague is willing to do that for you. Apart from renal hygiene and glucose therapy, glucose lowering therapy, and blood pressure lowering therapy, we should also focus on nutrition. There is always this issue about protein restriction. But the thing is that zero point 0.8 to 1 gram per kg body weight of protein is allowed in patients with chronic kidney disease. And it is very rare. I mean, honestly, I have never seen any Indian diet crossing that. So patient can take a normal Indian diet. Maybe you can tell them do not take non-veg food 3 times a day. But still, up till 0.8 to 1 gram of protein is allowed. If your patient does not take protein at all, then the person will get malnourished. And that is called adult kwashiorkor. If you're stuck, you should refer. If the patient is deteriorating, you should refer. But otherwise, you can keep the patient with you. And this renal pentad again reminds us of when to refer a patient and when not to. This pentad was created by Professor Manisha Sahai from Hyderabad and Dr. Dinesh Dhanda from Karnal in Haryana. But Dr. Dr. Dinesh Khullar from Max Hospital, Saket, New Delhi, has added another point to this. And he says that all these 5 angles are important, but right at the center, you should have something called preparation for renal replacement therapy. So as the EGFR comes down, you should begin counseling your patient about dialysis, about kidney transplant, and begin preparing your patient for kidney transplant. If your patient has acute problems, sudden worsening in chronic problems, or worsening of comorbid conditions, do seek the help of a specialist. If, however, your patient is stable, renal function is stable, albuminuria is the same as it was before, EGFR is the same as it was before, there are no acute concerns, no infection or obstruction, then continue managing your patient. Let's look at the answers to last week's questions. So today we've spoken about diabetic nephropathy. We have a fair view. Let me remind ourselves of the most important interventions that we can do. Good nutrition with adequate protein, good glucose control, good blood pressure control, cardiovascular risk reduction, and renal hygiene. With this in mind, this question from last week, if you have a patient with a glucose of 950, high osmolarity, high PCO2 and high HCO3, and a pH of 7.4, the answer is hyperosmolar, hyperglycemic, non-ketotic coma. It is not diabetic neuropathy. It is hyperosmolar, hyperglycemic, non-ketotic coma. And the second question was, an isotonic solution is one which, the answer is, does not cause hemolysis. With this, we'll share this week's questions, and I look forward to meeting you again next week.